First, I do want to thank Chairman Lee Thompson, for making this happen, as well as Kay McNeil. And hopefully by the end of this presentation, you'll understand why this topic is so important. So today I'm going to talk primarily about advocacy and how one goes about doing that. And then next Monday, I'll be talking about reimbursement for our services. Okay? Now, if you want to ask questions, we have a mic here that we will locate at, we wanted to see how you all are going to be sitting down and where. So are we okay with this? All right. So if you have, yeah, we'll be able to really hear you. So if you have questions, please don't be shy and ask the questions. On this first slide, I did summarize as briefly as I could, especially my experience in advocacy and governmental affairs. And so I've worked at the national level with ASHA in their Healthcare Economics Committee. For 3 years, I chaired the National Medicaid Committee. So I got a nice picture about what's going on across the country with regard to Medicaid. And then I was on the Government Relations Public Policy Board for ASHA for 4 years. And that sets what we call now the blueprint for action. It used to be called the Agenda for Public Policy Actions across the country, in Washington as well as in states in the US. And then here more locally, I was chair and have continued to be very involved with the Ohio Speech Hearing Governmental Affairs Coalition. And I'll talk about that a bit later. So just so you know that those are my bona fides, as they say. So let's take a look at why advocacy is important. And we have to start by defining what advocacy is all about. Okay? And so it really is educating and influencing the key decision makers that are out there concerning the issues that are important to our clients or our patients and to our profession. That's what advocacy is. That's a very quick definition of advocacy. And why do we need to advocate? Well, if you're reading the papers, watching the news, you're sensing that we are competing for very diminishing resources. All right, partly because the kinds of things we do are being cut sometimes, and also because the population is growing and there's more need for it. So those are a couple reasons. The second important reason is we want to ensure that people who need our services have access to those services. All right? Third, to the extent that we can through advocacy, we want to improve the quality of the service we're providing. And part of that has to do with the access, certainly, but also the frequency and intensity of service that you can provide. So how many sessions a week, how long the sessions, and we'll talk a little bit about that. This fourth bullet is a very politely expressed concept, decreasing bureaucratic hurdles. I had other words that I've used in less formal encounters, but this suffices for this presentation. We need to educate parents and caregivers. And later this morning, you'll find out why that's important. We need to educate the decision makers, whether they are in Washington, or whether they're in Columbus, or whether they're here in Cleveland. There are all sorts of people at these three levels that are making decisions that impact on our profession, as well as impact on the clients that we are trying to serve. This next bullet is very important, balancing the concept of basic needs. When insurance plans are designed, they start with what are called essential benefits. What does the law tell the insurance company to do with benefits? And so there are basic benefits, and then there are these other, shall we say, less basic benefits from their point of view, from the insurance company's point of view. They're going to sell as small a benefit package as they can to maximize their profits. That's how it works. And so we need regularly to remind insurance companies and insurance commissions in Columbus or down in Washington that communication and the treatment of communication disorders is a basic need. So going back to undergrad, Psych 101, whatever, Maslow, the principle of the basic triangle, right? You remember all that. Well, we're trying to get communication management in that very bottom level of basic needs, counteracting the impact of term limits. And so Ohio is a term limit state, meaning that you cannot hold a representative position or a senator position for more than whatever terms, 2 terms right now. But what happens is that they do this. They orchestrate the process so that they can be in the House for whatever, then they get termed out and they go in the Senate. Then they get termed out and they go back in the House. So it's kind of an artifact that we need to deal with, but it's still there. But at the same time, there are some who choose not to do it again. You know, for whatever we read in the papers or see on TV, being a legislator is really hard work. And you have to be dealing with your constituents all the time. So sometimes they choose, I'm not doing this anymore, it's just not worth the money. So we need to educate a whole new class of legislators. All right, so the other thing is ensuring, obviously, the continued viability of our services, audiology and speech-language pathology. And that viability proceeds directly from the reimbursements that we are able to generate. All right? Educating audiology and speech-language pathology professionals. This is what we're doing today. All right? So we have a senator out there in Wyoming, Senator Henri. He's a U.S. senator, and he's come out with this statement that's very, very telling. And he says, if you're not at the table, you're on the menu. Get it? Right? So if you're not at the table, you're on the menu. And so if you're not pushing your causes, because there are so many causes coming into their offices, so many people who have different needs, if you can't get at the table arguing your needs, you're on the menu. So let's start at the national level. And ASHA has a phenomenal advocacy effort, and it has for many, many years. And so ASHA's Government Relations and Public Policy Board works with the membership. We have now, I don't know, 165,000 ASHA members throughout the country, so it's pretty impressive. And what it does is every year it establishes this blueprint for action, and typically, generally, there are 4 priority levels. And at the federal level right now is Medicare. There's a lot of concern about Medicare issues, for instance. A subset of the Government Relations Public Policy Board is the Healthcare Economics Committee. And that particular committee focuses specifically on anything that relates to coding or reimbursement. So I don't know if you guys have gotten into coding yet or you understand what coding is, but for instance, 92507 is our code for individual speech-language therapy. That's a code that comes out of this coding manual, and anytime you want to get paid for doing an hour or half-hour speech therapy, you've got to use that code, 92507. Well, those codes are determined by a committee of the American Medical Association. So we have to be on that committee. And it's a constant battle because everyone's pushing and shoving to get a piece of the action, right? So anyway, the healthcare economics addresses coding and reimbursement issues, getting paid. It also addresses what we call megatrends, the big stuff going on in the country. And of course, one of them right now is the Affordable Care Act, the so-called Obamacare. All right, so Obamacare throughout the country, the Affordable Care Act, has had a real significant impact on our ability to be, first of all, one of those basic essential services, and secondly, to get paid a reasonable amount for that. The next one is the Medicaid program implementation. And Medicaid, in contrast to Medicare, which I'll talk about next week, is really a partnership between the federal government and the state government. So that's very different than Medicare. Medicare is entirely federal. States have nothing to do with Medicare. But Medicaid is a partnership. So the state of Ohio puts up something like 30 cents to get 70 cents back from the federal government, whatever the ratio is. But that's generally what it is. And so it's a 30-70 split, as we say. So again, Medicaid across the country is consuming more and more of state budgets, and that's why there's so much reluctance to expand Medicaid, because state governors and state governments are saying, where are we going to get this money to pay for Medicaid? Where are we going to get all those little 30 cents that we need for Medicaid reimbursements? Now, what we did, and I'm very proud of this because we launched this in Ohio a few years ago. It's called STARS, State Advocates for Reimbursement. And it's a network across all 50 states, born here in Ohio. And what the STARS do is they have conference calls typically every month or two, depending on the hot issues and what's out there. And then they meet at the ASHA convention for a good part of the Wednesday meeting day. And they go over, again, issues going on across the country. So the STARS will address insurance companies and reimbursements for our services. They initially focused on Medicare, but now we've expanded their scope of attention to include all payers, public and private. And you'll learn all about that. These are teasers, all about that next week. All right? Now, of course, we have STAMP. You have the STARS for the public and private payers. And then because Medicare is such a huge issue, it's the largest payer in the country of our services, so we created STAMP. And STAMP is very similar to STARS, fewer in number. We haven't been as successful in getting as many stamps as we need. So that's one thing. But the emphasis is entirely on Medicare, and especially things that relate these days to the insurance cap. So Centers for Medicare and Medicaid Services, CMS, have determined that speech-language pathology and physical therapy will be under one cap. And the total amount there is $1,960 a year. And the more troubling statistic is that CMS tells us in the speech arena that roughly 75% is consumed by physical therapy, leaving 25% for speech-language pathology services. All right? So we have to deal with that every year, it seems, with regard to making sure that speech-language pathology is adequately funded. So, of course, the best situation would be to separate PT over here, speech path over here, and each of you get $1,960. Now, the weird thing about all of this is that OT over here, they get $1,960. So people do what you're doing right now, these quizzical, what the heck is going on faces. And it goes back, way back, to the late 60s when Medicare was being set up, and they were trying to define the therapy services. And speech, I have to say, was not particularly effective compared to PT and OT, and making sure that it was at the table. So it was on the menu, right? And so we ended up dividing our resources with PT, and generally we get the very shortest end of the stick. Now, the Healthcare Economics Committee, this is the one that I chaired for quite a while. It was really fascinating to see what was going on nationally. And I have a slide that I'll insert here in a second. It's all queued up. But basically, what the HCEC does is it looks for problems across the country, and it figures out, helps everyone figure out how to deal with these problems. What did you do over here in Mississippi? Well, we did this. What about you up in Idaho? Well, we did this. So it was kind of cool. So in Idaho, we had a problem where, of course, the Department of Human Services in Idaho didn't want to reimburse for speech-language pathology services. So we said, oh, okay, that's not a problem. What we'll do is we'll ask every pediatrician to refer the little Medicaid kid over to neurology, and we'll run a bunch of PET scans, MRIs, whatever we need, and that'll cost X dollars, and then we'll get a diagnosis from the neurologist that allows us to treat this child. Well, when Idaho Medicaid saw what the cost of that would be, they went, whoa, 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 okay. So, you know, now everybody in the country knows what Idaho did. And so we use these little tactics to help our profession. The other thing that's out there are these Medicaid insurance commissions. And what they are is auditors. And they come in either to a state or to an agency, a hospital, a Cleveland Hearing and Speech Center, whatever, and they sort of verify that what you've been billing them is correct and is a service that's covered. And so that's another issue that we have to make sure is well administered. Documentation and record keeping, what needs to be in a file. If it's not in the file, if it's not written down somewhere in an electronic or a handwritten medical record, it never happened. That's how Medicaid thinks. And so documentation and record keeping. What must be in the record so that we can get paid? Next thing has to do with managed care contractors. So now every state in the country under the Medicaid program has to contract with providers in the state. And in Ohio, we have 5 that we contract with. CareSource is the biggest one we deal with here in Cleveland, but we have Buckeye and all these others. And so you have to get an agreement with each of those. You have to be site visited with each of those. You have to pass what are called these different orientation programs. You have to have all the different fee schedules. It's a nightmare, all right? And at the same time, we have to manage how it works. Credentialing providers. So they used to credential individual providers. Now we finally got them to credential just the organization. So one credential process. So if you work at Cleveland Hearing and Speech Center, we are credentialed, and so you are credentialed. But in the past, I mean, it was just lugubrious. So there's a fun word for you. Supervision, what constitutes adequate supervision under the Medicaid program? And in the schools now, many school districts across the country are billing Medicaid for kids who are on Medicaid, and it's adding a whole other series of issues. Telemedicine and telepractice, big. Not for Ohio. Ohio's decided we're not going to reimburse telepractice unless it happens in a hospital. But if you're over at Cleveland Hearing and Speech Center, we're not allowing you to do telepractice. And so we're fighting that battle right now. EPSDT is a chapter of Medicaid, early periodic diagnostic, screening, diagnostic, and treatment. And EPSDT requires states to provide our services. Under EPSDT, we are an essential service, okay? Medical necessity is always a challenge. Is what you're doing medically necessary? Is it related to an injury, an illness, or some kind of disease? All right? The goal is to resolve these problems, whether nationally or by state actions, and within the ASHA membership. You know, we've got situations, and you all get ASHA Leader? All right. So every once in a while in ASHA Leader, there's an article by the Ethics Board. All right, so the Ethics Committee gets reports to it, and what the Ethics Committee is charged with doing is looking at the ASHA Code of Ethics, which are coming out brand new, March 1st. We'll talk about that next week. And so, you know, what we want to make sure is that people are behaving ethically. The most egregious issue is fraud. It's not like, it's kind of like that commercial, you know, fraud protection versus frog protection. I love that commercial. So we're on the right track here. So anyway, Medicaid fraud is billing for something you didn't do. Bad, really bad. And if you get caught in Medicaid fraud, bye-bye, I'll be sending you books and sandwiches, you know. The Tri-Alliance is another thing that we do at a national level, and we try when the issues are overlapping and they are serving common interests to work with the American Physical Therapy Association and the American Occupational Therapy Association. And every once in a while, you know, we're able to get the heads of those programs together, sometimes at the ASHA National Convention on Wednesday, Committee Day, and we talk about what's going on with PT, what's going on with OT, how can we work together to solve this problem? So you can bet that the Physical Therapy Association really knows quite clearly that we are trying to get that 1960 for our discipline as well as theirs. We don't want to take money from them, but we do want our fair share. So the challenge always is balancing interests and what's common to these three disciplines versus not. And the committee meets on a PRN as need basis. All right, how you guys doing? All right, so Medicare administrative contractors, they're kind of like the mix. You know, so we have the Medicaid contractors, now we have the MACs, the Medicaid administrative contractors. And for Ohio and Kentucky, it's the Solarian group, which everyone has heard of course. No. And so what the Solarian group does, as well as the other MACs around the country, is they bring us together every few months, again, to look at common problems. Some of the problems on both sides, the payer and the payee, can be resolved, and it saves money for both groups, right? So Medicare folks want their dollars to go as far as they can to treat patients, and we want to be able to use our Medicare time and resources as effectively as possible, too. All right, so it meets 2 or 3 times a year. It primarily addresses coding again. It addresses other billing issues and administrative problems, which is also a very nice, polite expression of problems, so as that we can decrease expenses on both sides, as far as the payer is concerned, Medicare, and as far as we are concerned, because it costs money. You know, when the Medicaid contractors came online, we had to put on 2 new billing persons at Cleveland Hearing and Speech Center. And so with compensation and benefits, that's another $80,000, $90,000 that we're not using for providing services to people. We're using it to process payments. So here's some victories we've had at the national level. Now speech-language pathologists can bill Medicare directly. So you can bill Solarian Group directly and get paid. That wasn't always the case, believe me. Patients that receive speech-language pathology services under Medicare no longer need to be seen, every 30 days by their physician so that he can or she can reauthorize the treatment. You know, so when I was practicing, and I worked almost entirely with folks on Medicare, the doctors would say to me, "Gee, Dr. Henry, well, why do I need to do this? I mean, you know," so we've been working to just get rid of that step. It was for people, especially in rural states, who had to travel these tremendous distances to go see their doctor so they could get recertified for therapy. What a waste. Medicare plan of care, that's another thing that's related to the second bullet. And it had to do with the plan of care having to be reviewed every 30 days. Now we can get it reviewed every 90 days and get recertified for treatment, okay? What's going on right now nationally? Well, in some sectors, particularly audiology, speech path, but audiology has really gotten hammered under Medicare recently. And so ASHA is working, along with AAA, the American Academy of Audiology, to address that problem and see if they can recover some of the lost reimbursements. I've already talked about the impact of that $1,960. It really does restrict access, primarily financial access, to our services. We want to try to expand the coverage for audiology under Medicare, and this is a forever battle. And the big problem is that right now Medicare will not allow any testing or any services related to fitting a hearing aid. And really easy to figure out why. The cost, they're trying to get a hint, what would this cost us? So I think right now we're working with some folks down in Florida, and what we're trying to do is at least get them to cover the diagnostics. If they can't cover the hearing aid instrument, we kind of get that, because the hearing aid companies are all over the place on what they charge for a hearing aid. But the issue is really that it reduces access to older folks, generally, who need hearing aids. And there's all these corollary problems that, you know, like my mother-in-law is in a nursing home. She's only 97 and a half, and she's been there for 10 years or whatever it is. She had a hearing aid, and I don't know what happened to it, but it's gone. But the problem is that she can't understand what people are saying to her. So then they think she's demented. No. They think other things, you know, and so it really disrupts the communication between her caregivers and her and this facility. Medicaid payments, as I said, are all over the place, and all over the place means probably the worst in the country is Vermont. So they pay about $12 for the diagnostic code. Who can do that for $12? I don't know. And then otherwise, if you want to set up a practice, you can go to Texas or Alaska, because their diagnostic codes are paid at about $180, $85 per code, Vermont 12. So that gives you a sense of the range. And this is a ranking. This is to get on Medicaid in any state. The state determines how much income the family can have before it's eligible for Medicaid. All right? So in the great state of Arkansas, you have a family of 3. You cannot make more than $3,133. If you go $3,134 in the state of Arkansas, you are not eligible for Medicaid as a family of 3. All right, now so let's look at Ohio, because that's always fun. Ohio is $18,766, so a little more reasonable, and you can see it's kind of at the 60th percent of the range there from top to bottom. Folks in Minnesota, a family of 3 can make $41,990 and still be eligible for Medicaid in the state of Minnesota. So I won't get political, but you can run down, I'm not Kay. I won't get political, but you can run down through the states and you can look at who's doing what and say, I know what's going on here, right? So that's another whole set of advocacy stuff. And so it was originally around $1,350 when they first set this up. And so every year we've been bugging CMS to get a more generous payment. But it was my best and honest recollection, it was kind of pulled out of the sky. Actuaries, you know, actuaries are the people who are the number crunchers, they're kind of sort of statisticians, but actuaries are the ones who come up with rates. So I'm betting that a group of actuaries at CMS looked at all the payouts for PT, OT, speech, looked at the number of units. Okay, so they know how many times PT was billed, they know how many times speech path was billed, they looked at the pot of money they had, and then they said, okay, based on units X, we'll give this much to PT, we'll give this much to SLP. That would be my guess, having watched them operate. And, you know, we have a very good relationship with CMS. So I've been there twice in Baltimore. And, you know, it's kind of like going into an ultra super secret facility. They put mirrors under your cars. You have to go through all these X-ray machines. You have to do the lyrics to Neutron Dance. Just strange stuff. But anyway, the point is that it's a very tight facility. And you get in there, the people are very nice, and they want to work with you. Another part about advocacy that I should have probably made a slide is, it's all about relationships. You're constantly building relationships with the folks in federal government, whether it's the congressmen and senators, whether it's the folks at CMS or Department of Human Service, Department of Education. Those are the people that ASHA is constantly meeting with. And I want to underscore constantly. They work, we have a 16-member advocacy team at ASHA, and they work very, very hard for us and for the members. Okay, so we don't need an early hearing, EDI as that's called, early hearing detection and intervention, is money that each state gets from the federal government. President Obama re-signed it a couple years ago, so we're good for a while at least. And it helps fund early intervention to kids with hearing loss. All right, so here in Ohio and here in Cleveland specifically at the center, we have the Regional Infant Hearing Program, and it works with newborns up to age 3 who've been found to have hearing loss or deafness, right? And so the EDI money is part of that. And We have to work very hard again to make sure that there's an adequate amount. Right now it's $1.5 million that comes into Ohio, which doesn't sound like a lot to me. We have about 450 to 500 kids born every year in Ohio who have significant hearing loss or are deaf. All right? The Affordable Care Act, I've talked a little bit about that. We're still learning. This is a process that's been unfolding. I know that Obamacare has been around for a while, and I know that a lot of people don't want Obamacare, but it's there. And they're pushing a building up a mountain right now, trying to get rid of Obamacare or the Affordable Care Act. But we want to, here was one of the battles we fought. They understood rehab. They understood a person having an accident or having a stroke or developing MS or some condition like that. They got that. And that the person needs speech therapy as a result. They didn't get habilitation, you know, especially with kids. So whether it's insurance companies or other payers, they don't get, well, they never had it. So why do we have to pay for this? So it's a real big problem. So I underscored habilitation just to make you understand that it's something we constantly have to argue for. So I would urge you to go to the ASHA website. First of all, you'll be amazed at how many articles there are on advocacy. I think it's about 3,800. I've got it on one of my slides, but I was like, whoa, 3,800. But the one you want to go to really quickly up in the search bar, just put Blueprint for Action 2016. It'll pop up, it's 4 or 5 pages, and it'll tell you, here's what we're working on your behalf for speech, language, hearing, and audiology services. All right? So please do that. So I just put that in there just to... Dr. Henri, my brain is full. May I be excused? Anyone want to be excused? All this stuff coming out. All right, never mind.
I have a question.
Sure.
What does advocacy for coding look like?
Oh, boy. Well, so you've got the American Medical Association. And that's the association for all the doctors in the country, right? Any kind of doctor. Then you have the subspecialties, neurology, pediatrics, whatever. But you have the AMA. And inside the AMA is a group called the Resource Utilization Committee, the RUC. Resource Utilization Committee. And ASHA, for many, many years, has been at the table, not on the menu, at the RUC. The RUC meets all over the place, Chicago, New York, Los Angeles, Puerto Rico, and they meet there for these intensive 3- and 4-day meetings to look at coding. So not too long ago, about 2 years, ASHA decided the 92506 code, which was our one diagnostic code, was not enough. And so we worked and worked with the RUC, especially, and with the other coding entities under the diagnostic code system, to get that one code separated into 4, right? But it requires, we have a gentleman from Florida, Dr. Pfeiffer, and Dr. Pfeiffer has been on the RUC, boy, I want to say 20 years. It's really, and he is unbelievable. He knows the coding system inside out. And when you build a code like 92507, it's got to be constructed with these little variables in place. So the first one is the professional portion. That means us. You know, what do we cost for this code and this service? Then there's a whole other thing that relates to malpractice insurance. Then there's another layer that relates to tongue blades and depressors and audiometers and all that stuff. So equipment. So those 3 things are factored into the code. And that's the RUC's job to determine the value of each of those. All right? And so when they set a fee, they look at these values that, again, the actuaries and the number crunchers, they develop what should be, and they recommend to the RUC, here's what this code includes in terms of professional service. All right, so here's where audiology took a big fat hit because there are some on the RUC and some in general in medicine who don't understand why you need an AUD or some other advanced degree to do a hearing test. My God, my nurse does that. You know, I don't, what? You need a doctorate to do a hearing test? Give me a break. And so they really took a hit on the professional part. All right, so their fees went down. So now they're fighting to get it back. And you know that's not an easy battle, right? So anyway, we can move on from that. One's brain is full. So now let's move into Ohio. We were in National, Washington, Baltimore, where all this stuff happens. And then in Ohio, we have a particular interest as an organization, Ohio Speech Language Hearing Association, to promote legislation, rules, and regulations that relate to our services. So many years ago, I want to say 30 or 35 years ago, Ohio formed the one-of-a-kind group called the Ohio Speech Hearing Governmental Affairs Coalition. We call it GAC. That's the short version. And the GAC consists of the Ohio Speech Language Hearing Association. It consists of the Ohio Council of Speech and Hearing Administrators, the Ohio Academy of Audiology, and then the Ohio School Speech Pathology Educational Audiology Coalition, OSPEAC, and it's the only such entity in the United States. We get so many great compliments from our colleagues around the country for this organization, and it's been immensely effective. And that's why STARS began in Ohio. And I had a little to do with that. So what GAC does is we work with Ohio Governmental Policy Group, which is one of the state's largest advocacy organization or lobbying organizations. All right, so Brooke Cheney is the head of that. We've worked with Brooke forever. But what they do is they say, as they say, pound the halls for our issues. They bring us to legislation. You know, they set up all sorts of things. And at the same time, they provide us with a lot of guidance and a lot of interesting information on how to proceed with our concerns. The speech language, here's the big one right now that we're dealing with. So I don't know if any of you are going to the OSHA convention in March. Saturday, here's another teaser. Greg Thornton and I are doing a 3-hour course on ethics. Ethics for 3 hours? What could we be talking about? That's the teaser. You know, but it's now a national requirement. ASHA made it a national requirement that to get your license in a particular state, you have to do 2 hours of ethics training every year. It's kind of a, you know, preventive measure. So right now in Ohio, we're looking at licensure board operations. You know, the General Assembly and the governor's office, they don't want licensure boards. They think that the legal system can deal with that stuff. You know, we've got laws. We don't need all that licensing thing. The problem is people generally don't have the resources to hire an attorney to go defend their situation. So we have licenses, but the other thing that they're looking at is how can we discipline professionals who break the rules? And right now we can take their license away, and so they can't practice. But you've got people in Columbus saying, oh, no, you can't take away someone's livelihood. You know, you can't take away someone's capacity to earn income for themselves and their family. So that's an arm wrestling thing that we're going on. Another thing that's going on right now is licensing and scope of practice for OTs and for music therapists who are trying to get into our stuff. No. You know what I mean? So another thing we do is we protect our scope of practice. This is what speech-language pathologists are trained to do and have the academic background to support it. I don't know what you're thinking, Miss Music Therapist, but you don't have that stuff. You know, we've had a constant battle with OT around swallowing. All right, you can imagine that one easily. So the next thing is funding of the infant hearing programs. Constant battle. And right now they want to take the infant hearing programs out of Ohio Department of Health and put them in the Ohio Department of Developmental Disabilities. And that's a real problem for us because what they would do then is they would assign these little kids and their families who have hearing issues to generic home interventionists, or whatever you want to call them, but they can't sign, they don't really understand deaf culture, that, you know, so we're fighting that. You're not going to do that. Medicaid hearing aid coverage for digital hearing aids for kids, we have it. For adults, we just got it. All right? And this is another point of advocacy. It only took us 9 years. All right? Took us 9 years to get coverage for digital hearing aids for adults on Medicaid in Ohio. Only 9 years. That's why I'm talking about you're in a different time zone. Current issues, Medicaid rates are always an issue in Ohio. Medicaid HMOs are limiting access, and since especially the beginning of 2014, we've had to do all these things. So what the General Assembly is trying to do, that's our legislature, they're trying to figure out how to rein in these costs, because the Medicaid portion of the state budget is taking more and more every year. The state budget is about $32 billion. Sounds like a lot of money, it is to me. But as far as Medicaid I think right now is taking about $9 billion of that. All right? So then you have to ask, why is that? What's going on? You know? Well, there are all these corollary issues that lead into people needing to be on Medicaid, right? Prompt payment. There's a notion out there called slow walking. Slow walking has to do with you submit a bill to the insurance company, and they say, are you Maria still? Okay. They say, oh, Maria, you didn't put a dot on your I in your name, so they send it back to you for you to redo it. They don't put the dot on your I. All right? That's called slow walking a claim. And they do this so that they can slow walk, and they have their actuarial data. You're the actuary today. And they have the actuary say, figure out how many people don't fight the claim denial. Well, it's about this percentage. Okay. You know, so we will slow walk Maria's claim and hope that she's in that percentage that doesn't fight. We know this. We know that 90% of fought claims are reimbursed ultimately. So it's worth the battle. Don't give up. But that's advocacy. Okay? Medical necessity, always a thing. That's kind of a generic way of denying a claim. It wasn't medically necessary. So I did a whole paper for ASHA on medical necessity, using definitions from all over the country to try to kind of find common denominators. What are the common elements of a medical necessity definition, beginning with Medicare's definition, then Medicaid's, but, you know, again, the states have their own ways of defining things. So I've been polite again, procedural problems, more polite verbiage, in dealing with provider credentialing. So Cleveland Hearing and Speech Center was trying to get credentialed by a particular HMO, right? So we submit all this ream of papers, credentials on all of our clinicians. It takes about 18 months to get credentialed. 18 months. In the meantime, the state's paying this outfit, you know, whatever, to provide Medicaid services throughout the state of Ohio. 18 months. They kept playing this game with us, wherein we would submit a claim for 10 visits, say, and then they'd deny it, and then we'd call, and they'd say, well, it wasn't properly authorized. Well, such and such authorized it. Yeah, but she or he didn't have the authority to authorize that claim. Okay, so they kept doing that. I come into the office one Tuesday morning, and Angela, who's there, says to me, Dr. Henri, such and such has denied a claim again. I said, oh, really? I said, give me the contract. And at the end of the contract, there's a page that allows me to drop off from that provider, cancel our arrangement. So I cancel it, fax the form to them, 18 months for credentialing. By 9 o'clock the next morning, we were off the panel. 18 months, 18 hours. Right, it's just, yeah. So, I think we got that. Department of Ed, that's a whole other issue. Their big problem is not enough speech language pathologists. in the schools. Why is that? Well, because caseload size, we've been fighting that battle since forever. And in Ohio, the caseload size is, depending on the school district, but somewhere around 55, which is the ASHA recommended number. But in some cases, in some districts, not too far from here, it's over 100. 110 plus 2 language classrooms. How can you do anything with a child who's in a group of 5 and has 25 or 30 minutes to get treatment once a week? Doesn't happen. So they're having trouble. And it's not like the speech language pathologists don't know this. You guys are smart. Oh, that district? Nope. You know. Caseload, workload, documentation, and work environment issues. This was a statement to me when I first started. Here I am with my sparkly new PhD, and I'm hired by a school district in southern Maine to come in and test kids who have special learning problems. So I'm doing it in this principal's office, and I've got my different tests, and I'm going to work and all that. Then, yeah, I open the door. Hi, Dr. Such and Such, our clinical psychologist is here. You're going to have to move. I said, oh, really? Yeah, you're going to have to move. Oh, okay. So they put me in the boys' bathroom. I said, that's a message, isn't it? You know? So another little battle. Anyway. This, I love this one. So we're fighting all these things in Columbus. Bill to be passed by the Ohio General Assembly that creates May 14th in Ohio as Childhood Apraxia Speech Awareness Day. You know, I don't want to be cynical. You need all that stuff. You need all that stuff to continue to educate the legislators. What the heck is childhood apraxia of speech? What are you talking about? That's a Greek word, isn't it? Yes, yes, sir, it is. We've got Greek words everywhere, Your Honor, you know. All right, U.S. Department of Justice versus CareSource. So this is interesting. CareSource is a big fat HMO in Dayton, and they got nailed for these 3 things: knowingly failing to provide services for beneficiaries with special health care needs, primarily children. Secondly, billing services that were not provided. That's fraud. Bad. Collecting unearned incentives. So the state incents them, gives them a bonus if they keep their spending under. So by not providing services to certain beneficiaries and paying for those services, they keep their reimbursements down. And anyway, so they got sued $26 million. Now you would think that the CEO of that outfit would be, no. All right, current issues in the county. Again, having to do with declining resources in Cuyahoga County, more people needing services, creating financial stresses, especially on the DD board. So the Developmental Disabilities Board provides a huge range of services across the county, and they're also being hit from state level and from county funding. Speech services and Head Starts, constant challenge. So we're fighting these battles all the time. You can't believe how effective graduate students are when they're confronting legislators about services. So we have a special day. These are issues that are in your PowerPoint. So who can advocate? We got about 12 minutes. This is where it gets really fun. All right, any questions? All right, quick story. Stories are always more effective. So I'm in Maine. I'm running an agency in Maine, Speech and Hearing Center. And we've been fighting for, oh, this is the good part. Rats. We're fighting with Blue Cross Blue Shield in Maine, which is the biggest payer in Maine. And especially, they have the contract with the Maine Teachers Association. So we've been working with them for 2 years to get more visits and to get a better reimbursement. More visits, better reimbursement. We're getting 30 visits, and they're paying us about $38 a visit. Work. They want to know how many visits, you know, how many units for artic, how many units for language, you know, going on. And we do all these studies in the state, and we bring them back. 2 years of this baloney. But it's a different kind of slow walking process. So we find a mom in Bangor, not Bangor, and we find out that she has a little girl, 2 years old, with hearing loss that's been seen at the Bangor Regional Speech and Hearing Center, getting therapy there. Well, all of a sudden, Blue Cross decides, we're not doing this, we're not paying. Oh, okay, really? So we get the mom to come to one of our state meetings, and we tell her, here's the problem we've been having with Blue Cross Blue Shield. We bring her into Portland where the Blue Cross offices are, and we have her meet with the two big shots that we've been meeting with. And she says, you know what, I'm the vice president of the Maine Teachers Association. I want you to know that next week, my colleagues and I are going down to Hartford in Connecticut, and we're going to be pricing out new contracts so that we can make sure that we have adequate coverage in the state of Maine for hearing speech services. By the way, my daughter's 2 inches of hearing loss. You guys just denied her. See you later. This is what we're doing. So the big shot says, wait a minute. He goes into his office with the other guy, comes back. Here's what we're going to do. Right now, you guys are getting 30 visits. We're going to give you 70 visits. Right now, we're paying you $38. We're going to pay you $54 a visit. That meeting lasted about 20 minutes. Here, we've been diddling around for 2 years, right? So the most effective advocate is a parent, a guardian, someone who doesn't have, as far as the insurance company is concerned or the legislators are concerned, a sort of vested interest in the issue. So we try to find parents all the time, and we have parent coalitions. We launched a program here at Cleveland Hearing and Speech called Mothers on a Mission. We're still trying to make it work, get off the ground. Clinicians and speech pathologists can be effective advocates. Professional organizations, certainly ASHA and OSHLA, are doing that work for us. Voices for Children is a statewide entity that advocates in Columbus especially for services for kids. Agency representatives like the Head Start directors, they can be good advocates. Educators, professors and teachers, executive director types and other administrators, and lobbyists. I put lobbyists at the bottom because they're paid to do that. So they've got a sort of different kind of credibility in Columbus. But parents, think of Mrs. Bangor. Holy cow, 20 minutes? Should have found her at the beginning of that 2-year process. Creating an advocacy plan. First of all, you've got to work with a lobbyist. There's just no way you can get on a legislator's or bureaucrat's radar screen by yourself. You can't do it. So you've got to work with a lobbyist. And as I say, we work with Governmental Policy Group, but we also work with Governmental Action Group in Columbus for deafness issues. And you have to work with these lobbyists very closely. So we meet with our GAC folks once a month. And we have an agenda that we put together in January. We look at the federal agenda, the Blueprint for Action, but at the same time, we look at what is unique to Ohio in terms of our services and our clients. And we put together a plan for that. You have to be strategic. Strategic means thinking long range. And think of the hearing aids, 9 years. You know, we have some folks in this state who worked for 9 years to get that coverage for hearing aids for adults. You've got to identify a specific issue. And what happens often is people will come in with a list, an enumeration of all sorts of things. And the legislator just going like this or falling asleep or whatever. And you have to say, no, he'll tell you, she'll tell you. What's the most important thing for you right now? And then you've got to identify it. So it's much smarter if you've already done that. And you come in with, this is it. This is the issue that, Senator, you can have statewide impact. Okay? Do your homework, prepare, and then prepare some more. You've got to be ready. You can't go in there and be Miss Fumble Bumble, you know, and not got your thoughts together. Anticipate the questions. Pretend you're the legislator and sitting in that chair. Anticipate the question and prepare well supported. I knew you were going to ask that, Senator, and here's the answer to that, and here's how it's going to work. And this is the impact, economic impact, we'll have on the state of Ohio. Creating the advocacy plan must be carried by a champion. A champion is usually a legislator in the legislature that has had a personal experience with the problem. So we've got some legislators who actually are dealing with hearing loss themselves or in their family. So we've talked with them about the impact of hearing loss. And so it's better if they have some sort of experience with the issue. It's no longer about being nice to people. It's about what's the return on investment. If we give you $250,000 to do this, what's going to be the return of this investment to the state of Ohio? That's what they're wanting to know. All right? You need to follow through. Success requires repeated meetings. This House Bill 386, this is a joke. And when I presented it to my board 3 years ago, they just kind of looked at me like I just landed from Mars, you know, the Martian. And it was to sell bingo tickets through bars and taverns across Ohio, and the proceeds from those tickets, bingo, you know, scratch-off tickets, would go to support your services. And the board looked at me like, Bernard, have you lost your mind, or what the heck is, you know, so we didn't. But I'm just telling you, that's sometimes. So here's a very important sheet that you've got there. This has to do with sales. And advocacy, there's no getting around it. Advocacy is sales. It's sales, sales, sales. You're selling different products, but it's sales. 48% of salespeople never follow up with a prospect. That's so common in advocacy. They meet with a legislator or a bureaucrat once. Oh, good, we had that done. Forget it. You know, 25% of salespeople make a second contact and then stop. So this details who the successful people are made, what they're having to do. It's made on the 5th, 6th, 7th, 8th contact with the particular vendor or legislator or bureaucrat that you're trying to influence. So I can't believe we did this. But anyway, here we are, creating an advocacy plan. I was wrong. I said 3,800. It's 3,180 advocacy references on the ASHA website right now. So when someone comes to me and says, geez, I don't know anything about advocacy, I couldn't possibly do that. I say, well, have you gone to the website? Well, no, I really haven't. Go to the website, please, and just look at a few things, you know, and see what's going on with your profession, your future, your livelihood, and tell me what's going on. Boink. This is something you can do, doesn't cost a whole lot of money. There might be some possible, I don't want to put Dr. Vick in any precarious position here, but there might be some resources Cleveland Hearing and Speech might make available. But on April 5th, in the State Office Building atrium, every year we're going to have our Meet Your Legislators Day, all right? It's very well run. And so you get a name tag, and it has a little number on it, and it tells you what table you're sitting with. All the legislators, they get a name tag, it has a number on it. So fives all go to the fives, and, you know, and then they all get to know each other. It's back to relationship building, you know. And it's, I'm sorry, I forgot to put the time, but it's from 5 to 7:30 roughly. So you drive down there, have a sort of stand-up high table cocktail thing, and then you drive back. All right? And so it gives you a chance to meet with your legislators. So we have 2 minutes. Any questions? Yes?
Just hearing all of the different aspects that go into advocacy, such as framing your argument,
Yeah.
you're going in, building relationships, the ethics of everything. It reminds me a lot of what I've learned through like philosophy classes.
Mm-hmm.
Has there been a push to implement any courses for like graduate students in that area, or is that?
Well, there's courses in, I mean, you know,
Yeah, like for specific to speech language pathology, like an advocacy course that would cover some of
oh yes, 3,180 articles. So if you go into there, you can put in grassroots, all right? And there's a whole plan, a binder and DVD that walks you through a grassroots advocacy plan. So, again, to get only minimally political, what President Obama did that was very unique in 2007 and 8 is this grassroots process, right? He worked, $10 you want to give me? No, thank you very much. Great, appreciate the help. You know, and he did this and his team nationally. Well, you know, the other side's going, what is he doing? Well, now you're looking, everyone's doing that. So that's grassroots. That's right in the neighborhood, going around, banging on doors. Here's a little bit of information about our issue, about our candidate. I hope you can help us. So there's all sorts of guidance. At ASHA, there's typically presentations. It's not the most razzle-dazzle stuff. And at the same time, we found that if you don't do it, boy, all sorts of stuff happens. You're on the menu. So I'll leave you with that. Do you have other questions? I'm sorry. No? Okay. So I'll leave you with that. Next week, reimbursement. So thanks for coming. I appreciate your attention and I appreciate your taking the time. Okay? It's really important stuff.
Thank you.
You're welcome.